Welcome to our medical podcast, designed for clinicians from residency to advanced practice. In today's deep dive episode, we turn our attention to a common and clinically significant comorbidity encountered in the hospital setting, the intersection of anemia and congestive heart failure. It's a scenario familiar to anyone working on the medical wards. A patient is admitted with acute decompensated heart failure, struggling with dyspnea, fluid overload, and profound fatigue. As the initial lab work returns, you note a finding that complicates the entire clinical picture: a low hemoglobin. This is not a rare occurrence. In fact, studies have shown that anemia is present in a striking number of patients hospitalized with a primary diagnosis of congestive heart failure, with some research indicating a prevalence of over 50%. For many years, anemia in this context was often viewed as a mere bystander, an expected consequence of chronic illness. However, a growing body of evidence has compelled us to rethink this perspective. Anemia is now understood not just as a marker of disease severity but as an active participant in a vicious cycle that drives heart failure progression, increases symptom burden, and leads to worse outcomes, including more frequent hospitalizations and reduced quality of life. The relationship is complex and bidirectional. Heart failure can cause anemia, and anemia, in turn, can exacerbate heart failure. It creates a challenging clinical dilemma, as the symptoms of anemia, fatigue, weakness, and shortness of breath are nearly indistinguishable from the cardinal symptoms of heart failure itself. Throughout this episode, we will meticulously dissect this critical relationship. We will begin by exploring the fundamentals, delving into the intricate and multifactorial pathophysiology that links these two conditions, from hemodilution and iron deficiency to the cardiorenal anemia syndrome. We will then transition to the practical aspects of clinical presentation and diagnosis in the inpatient setting, focusing on how to systematically work up anemia in a heart failure patient and navigate the nuances of interpreting key diagnostic tests. Following that, we will conduct a comprehensive review of management strategies, critically examining the evidence behind iron supplementation, the role, or lack thereof, for erythropoiesis-stimulating agents based on landmark clinical trials, and the appropriate use of blood transfusions. Finally, we will explore advanced insights, discussing current controversies, areas of ongoing research, and practical pearls for the seasoned clinician. Our goal is to provide you with a robust framework for diagnosing and managing anemia in your hospitalized heart failure patients, empowering you to improve their functional capacity and clinical outcomes. To begin, let's establish the fundamental concepts, starting with the epidemiology and etiology of anemia in congestive heart failure. The prevalence of anemia is remarkably high in the heart failure population. While it affects approximately 30% of stable ambulatory patients, this figure escalates to around 50% in patients admitted with acute decompensated heart failure, the very patients we manage in the hospital. Anemia is typically defined according to the World Health Organization criteria, which is a hemoglobin concentration less than 13 grams per deciliter for men and less than 12 grams per deciliter for women. What is crucial to understand is that the development of anemia in this population is not due to a single cause but is profoundly multifactorial, a convergence of several interrelated pathological processes. One of the primary contributors is the state of chronic inflammation that characterizes heart failure. Heart failure is associated with the activation of the immune system and elevated levels of circulating pro-inflammatory cytokines, such as tumor necrosis factor alpha, interleukin-1, and interleukin-6. These cytokines wreak havoc on red blood cell production in multiple ways. They directly suppress erythropoiesis in the bone marrow, blunt the kidney's ability to produce erythropoietin, or EPO, and most importantly, they interfere with iron metabolism. Inflammation triggers the liver to produce hepcidin, a key regulatory hormone. Hepcidin acts to sequester iron within macrophages and reduces intestinal iron absorption, leading to a state known as functional iron deficiency. In this state, the body has adequate total iron stores, but that iron is locked away and unavailable for use by erythrocyte precursors in the bone marrow. This brings us to the second major pillar, Iron deficiency itself. Iron deficiency in heart failure can be either absolute, meaning total body iron stores are depleted, or the aforementioned functional deficiency. Absolute iron deficiency can arise from poor nutrition, malabsorption due to gut edema from venous congestion, or chronic, low-grade blood loss, often from the gastrointestinal tract, which can be exacerbated by the use of antiplatelet agents or anticoagulants commonly prescribed to these patients. The distinction between absolute and functional iron deficiency is not merely academic, it has profound implications for diagnosis and treatment, which we will discuss in detail later. The third critical element in this pathogenic triad is chronic kidney disease, or CKD. The intricate and damaging interplay between the heart and the kidneys gives rise to what is known as the cardiorenal anemia syndrome. A majority of patients with heart failure have some degree of renal dysfunction. As kidney function declines, the production of erythropoietin, the hormone that stimulates red blood cell production, diminishes, leading directly to anemia. Furthermore, medications central to heart failure management, particularly angiotensin-converting enzyme inhibitors and angiotensin receptor blockers, can also modestly contribute to anemia by interfering with the renin-angiotensin-aldosterone system, which has a role in stimulating erythropoiesis. Lastly, we cannot overlook the impact of hemodilution. Patients with congestive heart failure, especially during acute decompensations, experience significant fluid retention and volume expansion. This increase in plasma volume can dilute the concentration of red blood cells, leading to a lower measured hemoglobin and hematocrit, even if the total red cell mass is not significantly reduced. While often considered a dilutional anemia, it frequently coexists with the other true causes of impaired red cell production. Therefore, when you encounter an anemic patient with heart failure in the hospital, you are witnessing the clinical culmination of this complex interplay between inflammation, iron dysregulation, renal impairment, and fluid dynamics. Anemia in this context is rarely simple, it is a signal of advanced, multi-system disease. The clinical presentation of anemia in a patient with congestive heart failure is notoriously challenging because the symptoms overlap almost completely. Patients with heart failure already experience fatigue, dyspnea on exertion, reduced exercise tolerance, and weakness. Anemia layers on top of this and exacerbates every single one of these symptoms. Anemia reduces the oxygen-carrying capacity of the blood. In response, the heart must work harder to meet the body's metabolic demands, leading to an increase in heart rate and cardiac output. For a heart that is already failing, this additional stress is poorly tolerated. It can lower the threshold for angina in patients with underlying coronary artery disease and can worsen feelings of breathlessness. Clinically, this translates to a patient who becomes winded walking a shorter distance, feels more tired throughout the day, and may present with signs of worsening cardiac function. You may observe physical signs such as pallor, particularly in the conjunctiva, a resting tachycardia that is disproportionate to their other vital signs, or a systolic flow murmur on cardiac auscultation, which results from the increased velocity of blood flow. Anemia is consistently linked to a worse New York Heart Association, or NYHA, functional class, a higher rate of hospitalizations for heart failure, and an overall diminished quality of life. It is a powerful prognostic marker, its presence signals a sicker patient with a more advanced disease state. Given the significant clinical impact of anemia in hospitalized heart failure patients, a thorough and systematic diagnostic workup is essential. The process begins with the initial laboratory evaluation, but the interpretation of these tests requires a nuanced understanding of the underlying pathophysiology we have discussed. The first step is confirming the anemia with a complete blood count, or CBC. This will provide the hemoglobin and hematocrit values. It's also important to examine the mean corpuscular volume, or MCV, which helps classify the anemia. While anemia can be microcytic, normocytic, or macrocytic, in the vast majority of heart failure patients, the anemia is normocytic and normochromic, reflecting an anemia of chronic disease or inflammation. The cornerstone of the diagnostic workup, however, is the assessment of iron status. This is where clinical practice must move beyond a simple ferritin level. In a state of chronic inflammation like heart failure, ferritin acts as an acute phase reactant, meaning its levels can be elevated independently of iron stores. Relying on a low ferritin alone to diagnose iron deficiency will cause you to miss the diagnosis in many patients with functional iron deficiency. Therefore, a comprehensive iron panel is required, including serum iron, total iron binding capacity, transference saturation, or TSAT, and serum ferritin. The key to diagnosis lies in interpreting the TSAT and ferritin together. The widely accepted definition for iron deficiency in the setting of heart failure is a serum ferritin less than 100 nanograms per milliliter, which indicates absolute iron deficiency. However, if the ferritin is between 100 and 299 nanograms per milliliter, you must look at the transference saturation. A TSAT of less than 20% in this context indicates functional iron deficiency. The iron stores are present but not accessible for erythropoiesis. This combined definition is critical and is used in major clinical trials and expert consensus documents. Beyond iron studies, the workup should also include an assessment for other contributing factors. A reticulocyte count is important to evaluate the bone marrow's response. A low count in the face of anemia suggests inadequate production. Basic metabolic panel should be checked to assess renal function, looking for evidence of chronic kidney disease as a contributor. It is also reasonable to check vitamin B12 and folate levels, as nutritional deficiencies can coexist, although they are less common causes in this setting. Inflammatory markers, such as C-reactive protein, can be helpful to confirm the presence of an inflammatory state that might be driving a functional iron deficiency. Finally, in patients where there is a clinical suspicion of gastrointestinal bleeding, such as those on multiple antithrombotic agents or with a history of ulcers, testing for fecal occult blood may be warranted. The differential diagnosis for anemia in heart failure is broad but can be systematically narrowed. The most common etiology is a combination of anemia of chronic disease and functional iron deficiency. This is followed by absolute iron deficiency, anemia related to chronic kidney disease, and hemodilution. Less common causes include primary bone marrow disorders like myelodysplastic syndrome, or drug-induced anemia. By using the comprehensive workup we've outlined, starting with the CBC and MCV, moving to a nuanced interpretation of iron studies, and rounding out the picture with markers of renal function and inflammation, you can accurately diagnose the underlying cause of anemia and pave the way for targeted and effective management. Once the diagnosis of anemia and its likely cause is established in a hospitalized patient with heart failure, the focus shifts to management. The primary goals of treatment are not necessarily to normalize the hemoglobin value, but rather to improve the patient's symptoms, functional capacity, and quality of life, and ultimately to reduce the risk of rehospitalization. It is important to note at the outset that, while these surrogate outcomes can be improved, a clear mortality benefit from treating anemia in heart failure has been notoriously difficult to demonstrate in clinical trials. The first and most important therapeutic intervention to consider is iron repletion, particularly for patients diagnosed with either absolute or functional iron deficiency. The debate here centers on the route of administration, oral versus intravenous iron. For patients with congestive heart failure, especially those who are acutely decompensated, intravenous, or IV, iron is strongly preferred. There are several reasons for this. Oral iron is poorly absorbed in patients with heart failure due to a combination of factors, including edema of the gut wall from venous congestion and the high levels of hepcidin, which block intestinal absorption. Furthermore, oral iron preparations are frequently associated with significant gastrointestinal side effects, such as constipation and nausea, which can lead to poor adherence. IV iron bypasses these issues entirely, delivering iron directly into the circulation where it can be utilized by the bone marrow. The evidence supporting the use of IV iron in heart failure is robust and comes from several landmark clinical trials. One of the first major studies was the FAIR-HF trial. In this study, patients with symptomatic heart failure and iron deficiency, with or without anemia, were randomized to receive 4-ferric carboxymaltose or placebo. The results were compelling. Patients who received 4-iron reported significant improvements in their symptoms, NYHA functional class, and their 6-minute walk distance. The AFFIRM-AHF trial later corroborated these findings with a longer follow-up period, showing sustained benefits. More recently, the AFFIRM-AHF trial focused specifically on patients hospitalized with acute decompensated heart failure. This trial demonstrated that administering 4-iron before discharge significantly reduced the risk of rehospitalizations for heart failure in the subsequent year. Collectively, these trials build a strong case for using 4-iron to improve how patients feel and function. The second major class of therapies that has been studied for anemia in heart failure is the erythropoiesis-stimulating agents, or ESAs, such as epoetin and darbepoetin alpha. These agents work by directly stimulating the bone marrow to produce more red blood cells and were once thought to be a promising treatment. However, this initial optimism was largely extinguished by the results of the RED-HF trial. This was a large, international, randomized controlled trial that evaluated the effect of darbepoetin alpha in over 2,000 patients with systolic heart failure and anemia. The trial's primary outcome was a composite of all-cause mortality or first hospitalization for worsening heart failure. The results were unequivocal. Treatment with the ESA did not reduce the primary outcome. In fact, there was a concerning trend toward an increased risk of stroke and other thromboembolic events in the treatment group. Based on the definitive results of RED-HF, major cardiology guidelines, including those from the European Society of Cardiology, now recommend against the routine use of ESAs for the treatment of anemia in patients with heart failure. Their use should be reserved for very specific circumstances, such as in patients with severe anemia related to end-stage renal disease on dialysis, typically under the guidance of a nephrologist. Finally, we must discuss the role of red blood cell transfusions. In the past, there was a lower threshold to transfuse anemic patients. However, our understanding has evolved toward a more restrictive transfusion strategy. Blood transfusions carry significant risks, especially in heart failure patients. The most immediate concern is volume overload. Transfusing a unit of packed red blood cells can precipitate or worsen pulmonary edema in a patient with a tenuous fluid status. There are also risks of transfusion reactions, infections, and immunomodulation. Therefore, transfusion should not be a routine treatment for chronic anemia in heart failure. It is generally reserved for patients with severe and symptomatic anemia, typically with a hemoglobin less than 7 or 8 grams per deciliter, or in the setting of acute hemorrhage or hemodynamic instability. The decision to transfuse should be made on a case-by-case basis, weighing the potential for immediate symptomatic relief against the substantial risks. The mainstay of management for the majority of anemic heart failure patients in the hospital should be the identification and treatment of iron deficiency, primarily with intravenous iron. As we move toward a more sophisticated understanding of anemia in heart failure, it is worth touching on some advanced insights, including ongoing controversies and practical pearls for the practicing clinician. One of the enduring debates in this field is the question of causality. Is anemia simply a marker of a sicker patient with more advanced heart failure and comorbidities, or is it an independent, modifiable risk factor that actively contributes to the progression of the disease? The evidence suggests the truth likely lies somewhere in between. While anemia is clearly associated with markers of disease severity like a worse NYHA class and higher BNP levels, the physiological consequences of reduced oxygen carrying capacity, namely, increased cardiac stress and tissue hypoxia, provide a strong rationale for its role as a direct contributor to the vicious cycle of heart failure. The fact that correcting iron deficiency improves symptoms and functional status, even in non-anemic patients as some sub-studies suggest, indicates that metabolic derangements associated with anemia play a key role. Another area of controversy and ongoing research is the optimal hemoglobin target for treatment. While we know that severe anemia is harmful, it is less clear what the ideal hemoglobin level should be for a heart failure patient. The FAIR-HF trial, for example, targeted a hemoglobin level that was perhaps too high, which may have contributed to the adverse events. It is possible that aiming for a more modest hemoglobin, perhaps in the range of 10 to 11 grams per deciliter, might offer symptomatic benefit with fewer risks, but this has not been proven. Future research is also exploring novel therapeutic agents. One promising class of drugs is the hypoxia-inducible factor prolyl hydroxylase inhibitors, or HIFIs. These are oral medications that work by stabilizing hypoxia-inducible factor, which in turn stimulates the body's own endogenous production of erythropoietin and also improves iron mobilization. They offer a more physiological approach to correcting anemia and are currently being studied in patients with chronic kidney disease, with potential future applications in heart failure. For the clinician on the wards today, there are several key practical pearls to integrate into practice. First, make it a routine to screen all hospitalized heart failure patients for anemia with a CBC and for iron deficiency with a full iron panel, including ferritin and transferrin saturation. Do not wait for the hemoglobin to be profoundly low. Second, when diagnosing iron deficiency, you must use the heart failure specific criteria, a ferritin less than 100 nanograms per milliliter, or a ferritin between 100 and 299 with a transferrin saturation less than 20%. Third, for most symptomatic patients with iron deficiency, prioritize intravenous iron over oral iron to ensure effective repletion and avoid side effects. Consider initiating treatment with a formulation like 4-ferric carboxymaltose before the patient is discharged, as this has been shown to reduce readmissions. Fourth, avoid the routine use of erythropoiesis-stimulating agents. Their lack of benefit and potential for harm have been clearly established. Finally, use a restrictive approach to blood transfusions, reserving them for patients with severe, life-threatening anemia or hemodynamic compromise, and always be mindful of the risk of fluid overload. In conclusion, the relationship between anemia and congestive heart failure is a critical area of focus for any clinician managing these patients in a hospital setting. Let us distill our discussion into a few key take-home points. First, anemia is exceptionally common in hospitalized heart failure patients, affecting up to half of this population. It should not be dismissed as an incidental finding, but rather recognized as a powerful marker of advanced disease, associated with a worse prognosis, increased symptom burden, and higher rates of rehospitalization. Second, the pathophysiology is complex and multifactorial. It is not a single disease process but a convergence of chronic inflammation, absolute and functional iron deficiency, and impaired renal function leading to decreased erythropoietin production. This triad is often referred to as the cardiorenal anemia syndrome and underscores the systemic nature of advanced heart failure. Third, a precise diagnosis is paramount and requires a nuanced approach. The workup must extend beyond a simple complete blood count. The cornerstone of diagnosis is a comprehensive iron panel, interpreting serum ferritin and transferrin saturation in the context of inflammation to accurately identify the large proportion of patients who have a correctable iron deficiency. Fourth, and perhaps most importantly from a therapeutic standpoint, management should be evidence-based and centered on improving patient-centered outcomes. This means prioritizing intravenous iron repletion for all symptomatic heart failure patients with documented iron deficiency, a strategy proven in multiple landmark trials to improve symptoms, functional capacity, and quality of life. Conversely, clinicians should avoid the routine use of erythropoiesis-stimulating agents, which have been shown to lack benefit and may cause harm. Blood transfusions should be reserved for cases of severe, hemodynamically significant anemia. By embracing this structured approach, systematically screening for anemia, diagnosing its underlying cause with the correct laboratory criteria, and implementing evidence-based therapies focused on 4-iron, we can move beyond simply managing fluid overload and begin to address the debilitating systemic consequences of heart failure, ultimately improving the lives of the patients we care for.